FNA using a needle with the Stylet or Trochar with the RPD. Cutting needles for biopsy and spinal type needles for aspiration both have an internal Stylet or Trochar that must be removed before aspiration. In these cases, after the needle has been anatomically placed, the Stylet is removed and the RPD is attached. 3 methods can be used to attach the RPD to the indwelling needle. The first method is to stabilize the needle with one hand and carefully rotate the RPD on with the other hand. The second method is to hold the RPD in one position and rotate the needle onto the RPD. This needle rotation method is preferred by many operators. The third method is to use extension tubing to attach the RPD to the needle. FNA using a pre-placed needle coaxial needle guide with the RPD. Certain FNA biopsies are most safely performed by first placing a coaxial needle guide that consists of a larger localization needle with an internal stylet. The FNA is performed with the second needle operating through the coaxial needle guide. In this technique, the coaxial needle guide is first placed using image guidance. The stylet or trochar is removed, exposing the biopsy site at the distal end of the coaxial needle. The FNA needle on the RPD is then introduced through the coaxial needle guide to the biopsy site. Once the FNA needle has engaged the target tissues, vacuum is induced by depressing the aspiration plunger, and the biopsy is performed in a standard manner. When biopsying lesions in the lung and the thorax, an air pocket may be encountered, resulting in loss of vacuum. This will markedly decrease biopsy yield if not recognized. With the RPD, loss of vacuum is immediately recognized by loss of resistance on the aspiration plunger. If this occurs, remove the needle, expel any sample and air above the cytologic slide, and repeat the procedure. Combined local anesthesia and FNA biopsy. In combined local anesthesia and FNA biopsy, 2 to 3 mL of lidocaine are placed in the RPD prior to the procedure. Using a fine needle, the skin, the subcutaneous tissues, and the deeper tissues up to the surface of the lesion are anesthetized. Once the needle tip has reached the tissue capsule or lesion edge, the remainder of the lidocaine is injected, leaving a dry RPD syringe. Then the biopsy is performed. This ultrasound clip demonstrates the needle administering local anesthesia prior to the biopsy. Fine needle non-aspiration biopsy with the RPD. Fine needle non-aspiration biopsy, known as FNA, is preferred by certain physicians instead of FNA, although the tissue yield with FNA is typically less than FNA performed with vacuum. Many experts recommend both FNA and FNA in the same procedure for optimal biopsy results. To perform FNA with the RPD is held in the pencil grip, the needle is introduced, and the biopsy is performed. To provide maximum diagnostic yield, both FNA and FNA are performed with the RPD in the same procedure.